Well, the headaches and the blurred vision, that's all side effects from what? Hypertension. Fetal edema, poor kidney function, swelling, right? Alright, once they turn into eclampsia, we give seizures, give the mag, and we give the benzo. Mag's a smooth muscle relaxant, also has some small anticonvulsant pills. That's why it can move up to the front. It can assist with the seizure stoppage. Did we do Previa? Previa is the painless bleeding.
Yeah.
It implants right over the what?
The cervix.
The cervix, right, yeah. The exit to the birth canal. Alright. What did I say abrupt is going to be? What kind of question?
Trauma.
Yes. 3 kinds of trauma that I've seen on National Registry for abrupt shield. What were they?
Car crash.
Car crash?
Fall.
Fall where?
Stairs.
Fall in the shower, fall in the stairs. Those are the three biggest things I've seen. Up until those 2 falls, I would have said it's always going to be ABC. But you have to have a shearing force, right?
Yeah.
To pull it away. Alright. So, now, a normal, before we go into problems with delivery, let's do normal childbirth. How many of y'all got to do clinicals OB? How many of y'all got to see live births? Everybody did? Believe it or not, that's becoming a
Well, in our vacation, we should have.
bet I can beat you with my clinical and my field experience. I was a black cloud. Parkland, EMT, 20.
20 deliveries?
Not a one spoke English.
Oh, shit.
I know how to do it in Spanish. In Puja, Desperado. Nerd.
Really?
Yeah. That's all you need. Look here, breathe, push.
Push.
That's it. Alright? And then I thought it'd be better, because everybody talked about they watch movies on their OB clinicals, paramedic, probably another 20. A lot. It was just Parkland and go room to room. My whole 12 hours was going room to room. Then I said, hey, but like first one I walked in, I was like, I'm not a doctor. They don't know that.
They don't know that.
That's how mine
I was
was.
there to catch. I was like, okay. And then got to Duncanville, got to my Dallas ride-outs, 2 field deliveries. Got to my Duncanville, 10. 15 degrees outside. She had her feet up on the door jamb when we walked up to the apartment complex. And I thought it would be helpful being the first one in, even though it was my partner's call. And I just dropped to my knees, and he goes, oh, I guess this one's yours, and he stepped over.
That's funny.
All of them have been good. Normal delivery. Caught my daughter. She's the only abnormal. She had 54. Alright. So, normal delivery. When they talk, it's different when they say it on the deal. So, anytime you see crowning, the answer is going to be, stop what you're doing, deliver right there. I don't care if you're going down the road. Pull over, deliver. We're always checking for crowning. Alright? So, I'm just going to walk you through it. It's very common sense. It makes sense. Just bear with me. I want you to hear it. Alright? Don't concentrate on your writing. Right now, this is just normal delivery. None of that normal stuff. Okay. When the heck comes out? Do babies come out like this? Shoulders east and west? Or do they come out shoulders north and south?
North and south.
The first thing we got to do is position them. Once the head delivers, we have to get them this way, right? You got to get, so when I say north and south, north is going to be your anterior shoulder. That A, P, posterior. Pick the alphabet. What comes first? A. That's the first shoulder we have to deliver. Why do we have to deliver the anterior? So it's going to apply, say, gentle traction. Get the baby into the side, or however, anterior, posterior position. All right? Why do we have to deliver the anterior shoulder first? Yes, the symphysis pubis. So we have a bone that we have to get under. All right? When that front shoulder gets stuck, something happens called turtling. All right? So turtling is, as soon as the head delivers, it keeps with every contraction, he keeps trying to suck back in. All right? That means you got shoulder dystocia. It means the shoulder's stuck. It was. You know what you do for that?
Whole heart.
I don't remember what it's called.
Mick Roberts. Yeah. Wish it had a different name. It's almost like ordering at McDonald's. It's like, I'll have the McRoberts. You know what I mean? But you do a McRoberts maneuver. I mean, now a Roberts maneuver means I'm going to pull your feet and your legs way back that way. All right? And I mean, to the point like we're stretching, we're doing this like, I got my shoulder into your, like in between the bend of your knee, and I'm going that way. And somebody else's shoulder in their shoulder into their crease in the knee, and they're going that way. You do that, and then what you do is, in the fundus, you're trying to basically help push, maneuver that shoulder to get it underneath the symphysis pubis. Now, if the shoulder is not stuck, then all we're doing, oh, you're locked? I'm sorry. I didn't know it locked. So, if the shoulder is not stuck, we're going to apply downward pressure to get the anterior shoulder to deliver first. All right, you're going to have to be a little rough with them. All right, so downward pressure, get the shoulder to deliver first. Once you get the anterior shoulder delivered underneath the symphysis pubis, the reason why we have to do it first is because we have to get under a bone. Is there any bone structure between the vagina and the anus? What do they call that area? Starts with P. Perineum. So the perineum is the area between that. There's a possibility there should be some ripping and tearing with the posterior shoulder delivery. If the bottom shoulder gets stuck, it's an easy deal. They do what they call an episiotomy. It's just a relief cut. That's it. All right. They sew it back up at the end. No big deal. All right. So once we get then we're going to apply upward traction to get the posterior shoulder delivered. Once we do that, that's when your game is on, because that's when they can come slip sliding. I'll just tell you, keep a C-clamp around that neck. No, you're keeping them from, you want a good hold on them for when they come slip sliding out, because they're slippery.
It's like a waterfall after them shoulders.
After the shoulders, it's right. Have we suctioned anything yet?
No,
Why do we not want to suction too early?
because their lung will span.
And, well, why is that bad for us?
They won't be able to.
They won't let it get out.
It could get stuck, a little more stuck. Could make the delivery a little bit harder. All right, so we suction, or we take the shoulder out, and then boom, game on, we deliver. How do we hold the baby? Position-wise, I'm talking about like, do we hold up? Do we hold below? Do we hold at the level of mom?
Put it on mom's chest.
Level of mom or below. Why? Because they're still connected to
The cord.
Still connected to the cord, and that's where they're getting their blood flow, right? All right. Now, what do we do now?
Clamp.
You got to clamp the cord, right?
Mm-hmm.
There's different books that are going to say different things. You're not going to see it clamp 2 to 3 inches, clamp 4 to 6 inches on the same answer. It's just going to be clamping the cord and cutting.
Mhm.
All right. Do we know what lives in the cord? What vasculature?
They got 2 arteries on it.
Yes. So think of it as like Ava lives in the cord. That's how I always did it, Ava. 2 arteries, 1 vein. So like when we do umbilical vein cannulation, we're using the veins, right? So basically we take a catheter, instead of doing an IO, which you don't want to do on newborn, or try to get an IV, we take a catheter we take a long catheter, I think it's 14 gauge, and I think it's like 2.5 inches, and we will cannulate that deal, and then we have like essentially a medical shoestring, and we clamp off the arteries so they don't bleed out. But we clamp off the artery, enough pressure to hold down the arteries, but not to collapse the vein. And I told you, arteries are hard to collapse, veins are easy to collapse. So it's kind of a fine line. So you kind of have to recheck that every now and then. But we only do that if we think we're going to need to give medications or fluids. So it could be a neonatal arrest scenario or a resuscitation scenario. All right, so we clamp the cord. Now what?
Wait for that placenta to
Before
deliver.
we stimulate, what do we do? And what do we suction first?
Oh, the baby.
How many holes is this?
One.
How many holes is this?
Two.
First place, second place.
Mm.
That's how you remember. Mouse 1, nose is 2. Alright, now we sit. So in the old days, what they do? Hold them by their feet, slap their bottom. How do we stimulate? Vigorous drying. Alright, now when they come out, you all saw the delivery, right? Coming out looking like an alien, right?
Yeah.
They're all hypoxic, right? Alright, what are we trying to, when we try to stimulate them to breathe, what happens when we stimulate them to breathe inside their system? What is that, there's a change that happens.
Just in like the close of the valve, what do they call it? In the heart, so it won't.
So inside the womb, they don't breathe, right?
Yeah.
They have essentially a bypass,
Mhm.
right? And that hole is called, when that hole doesn't close, they call it ductus arteriosus. But that duct closes as soon as it's supposed to close as soon as they breathe. And then their heart starts beating, right?
Mhm.
And they start oxygenating their own system. Now, if you put them on a pulse ox on 1 minute, normal is 60. So they don't get to 100% until 5 minutes in. So don't put a pulse ox on them. But it essentially goes with your Apgar, 1 in 5 minutes. Alright? So it's going to take a while for their system. Their system is starting for the first time. Alright? So they're oxygenating their lungs, oxygenating their body and their cells and everything, so they pink up. It gives them it. Alright? So once you stimulate them, you suction, then you stimulate them and everything, and they start breathing and crying on their own. Alright? Now we do, it's been 1 minute, what do? Apgar. We check their pulse, we check their grimace, their appearance, all this stuff. And I'll go through an Apgar with you and kind of show you how to, a little shortcut or whatever, how to do an Apgar. So you do your Apgar at 1, and then based off, what if their heart rate was less than 60? What are you going to start doing?
CPR.
Breathe for them.
You're going to start doing CPR. What if their heart rate is 60 to 100?
Ventilation.
Ventilations. Alright? And if they are cyanotic and you feel like they need a little blow-by, you base that off their heart rate. So if their heart rate's greater than 100, then you can give them a little blow-by. Okay? So you're going to keep drying, keep stimulating to breathe. You got them all worked up. Now, what do?
5 minutes.
Huh? We still got baby to manage. What do we got to do?
Give them the mom encourage her to breastfeed or?
Not yet. We got to do something about the baby.
Cover them up.
Cover them up. So we put their little what? You seen what's in if you looked at what's in an OB kit, you
Yeah.
put a little beanie in there.
Yeah, put
Prevent
it
heat loss. And then you swaddle them. Or do the full baby punching full.
Mhm.
Or whatever. I'll say not a towel, but a blanket.
Mhm.
Always keep extra blankets on your ambulance. I don't care if it's the middle of summer. But a blanket, you swaddle them up, no big deal. And some of them, I think, actually some OB
Mhm.
kits come with a swaddle versus
Yeah.
a baby punching full. Full, you can put around the deal, and full is just like whenever anybody ever cook meats and
Like
stuff
a
like
baked
that?
potato.
Yeah, prevents the heat loss.
Mhm.
Full works good like that. But if you can put a dry towel, a towel you wipe them off with, or you can put a blanket on, or if it's got a swaddling blanket, wrap them up in that, and then if you feel like they need more, then do that. Now, you could go skin to skin them on, but that's more hospital stuff. Alright? Now, we've dealt with that, and now we'll do our Apgar 5, and let's say everything's good to go. Alright, now comes the delivery of the placenta. I'll give you 2 scenarios. Contractions start again, and you see a rush of blood. And I mean a massive rush of blood. Should that scare you?
No.
It should be what?
Normal.
Anticipating. Because what is happening? The placenta is separating from the wall. So essentially, you have an abruptio placenta. Alright? There's a lot of blood flow there. Remember, they're carrying 1.5 times their normal volume. Alright? So, you don't see the early signs of shock. You know what I mean? Now, this is why we always want to start an IV on our pregnant patients if we can, or especially if they're in the delivery deal, is because, like, I know when my wife went in for my daughter, I think they loaded her up with, because she was pre-eclamptic with my son, but they ended up giving her like 4 bags of fluid before she even delivered.
Mm-hmm.
The reason why you do that is it's a preemptive treatment for shock, because you're going to get some volume loss.
Yeah.
All right. So open up the volumes, and now we got to stop the bleeding after the placenta is delivered.
Mm-hmm.
And it's always going to be, don't yank on it, just keep gentle traction on it, and then put it in a biohazard bag. Now, when you get done with that, we got to stop the bleeding. You already said, somebody said mom to start feeding.
Mm-hmm.
That's one way. What's the second way?
Fundal
Fundal massage, right over the uterus. It's both those things stimulate what? Production of what in the body?
Progesterone or?
Nope. Tocin. Oxytocin. So oxytocin makes it's muscle contraction. Uterus is a muscle. It stimulates muscle contraction in the uterus.
It's the cuddle
Huh?
hormone. I get it from cuddle.
Really?
Yep. Skin to skin.
Did not know that. Alright? So, if you stimulate the uterine to contract, that could tampen off the bleeding. Alright? It's also the same thing we give to stimulate, like when they say, hey, we're going to get induced. You know what they give them? Pitocin, which is it's a synthetic form of oxytocin. It stimulates contraction to expel the baby. There are studies going on right now. One of our doctors even proposed, there's a study right now of getting, instead of doing fundal massage or doing all that in emergency medicine, actually giving us Pitocin to give in the field for post-delivery to stimulate the contraction to stop the bleeding. Now, could this be a candidate for blood? Could be. Depends on how hypovolemic. I don't think they'll ask you anything about specifically giving blood, but be ready for it in the future. Most places are going to use it. I even know who works for Allegiance. I think I told you I met with that guy, and they're talking about giving it down here.
What fire department carries blood now?
Frisco, us, Dallas, Midlothian does. Lucas, Saxy does. Saxy does vents. Now remember I told you like vents will be the next big thing? They're getting vents that are like fireman proof. That's the big deal. I'd say we're big dumb animals. That has to be. Like to sell blood in our department, we had to do 3 different CEs on it and like go around to each station, and then by the end of it they go, oh no, this is easy. I was like, yeah, you're just hooking up fluid. That's like, the tubing looks a little different. That's it. And you have a warmer to go with it. But, the biggest decision on when to give it. And that's based off known bleeding source, shock index, and shock index is easy. If your heart rate's higher than your systolic blood pressure, you have a shock index greater than 1. Alright? I don't know if they'll ask you about shock index. Some people said, has anybody ever been asked about MAP?
Yeah.
They threw it in there, but I don't think
It was a main player. Do you know what an ideal MAP is? 65. And if they ask about head injuries in MAP, 65. So just remember 65 is your go-to answer for MAP. Does that make sense?
Mm-hmm.
All right. So get mom to stop bleeding. Fundal massage, all that. Get to oxytocin, and then I will say this: if they ask you in the scenario and there's a problem, we're going to go over some of the problems of pregnancy. And I've lived it. We had a breech delivery where the head was stuck. It was a cardiac arrest, everything, and they didn't even think to ask for an extra. Like I walked in and I go, "Hey, send us another ambulance," because now we always have 2 patients. Now, as long as everything's hunky dory, you can probably do it one. We're not trying to separate baby and mama. What we are trying to do is make sure that if one's critical, that they get the appropriate treatment. Does that make sense? All right, but that is normal delivery. Abnormal delivery situations. We'll start with the easy one. All right, baby delivers normal but the bag of waters is still intact.
You just hook on.
Tear it, and then treat it just like a normal delivery. All the post-delivery stuff, you just break the bag of water and go like that. All right. Nuchal cord. So, slip it around the neck. That's your first option. That's your least invasive, right? I thought there was going to be a big production. My daughter came out and she goes, oh, nuchal cord, and just goes, whoop, slips it right over the head. Now, I will say with nuchal cord, anticipate you might have to do a little bit more resuscitative care. Might have to back them. Anticipate their heart rate being lower. Depending on how many times it's wrapped, it can be wrapped 2-3 times, once, nice and easy, but you might have to do a little resuscitative care. So pay attention, you'll have to maybe bag them or even do a little CPR. All right? Now, if there's not enough slack to pull it around the deal, what are we going to do?
Just release the pressure, so like,
So
put your fingers in and kind of pull off through.
We're going to cut it. We're going to clamp, cut in between. So, stay right there, keep your head down. We want to do the cutting back here. So we're going to slip the clamps in right here. We're going to pull us a little deal, and we're always going to insert the scalpel away from your neck. The blade in, away from your neck. So we're going to be cutting away. All right? Why do we want to do it back here?
So you're not cutting
A lot of shit up here. A lot of dangerous shit. We got trachea, we got what? Jugular vein, carotid, a lot of bad shit up here. So we want to stay away from that as much as we can. So your two options are slip it over the neck or clamp, cut in between. All right? What's another delivery issue?
breech.
Huh? Breach. I'll hit breach right after this next one. Prolapse cord. All right? So, there are 3 situations in a delivery where you can put glove fingers inside the vagina. This is one of them. All right? We'll go through all 3 right in a row. All right? So, prolapse cord, what is happening? The cord's sticking out. Visualize it. The cord's sticking out. What's the danger in that? Every time she contracts and pushes the baby out, it's what? Acts like a tourniquet. So during every contraction, the baby's not getting what? Blood flow. All right? Now, how do we fix this?
Push it out. Go in and take the pressure off.
All right? We can't get the baby to go back in. We got to use a gravity assist. How do we get a gravity assist?
Standing.
Here, my guy.
Put your hands
I need you
on
to scoot back a little. I need you to get on this table. Sorry. I'm a woman for this. Sorry. I probably should. I was worried about Asian stuff. Don't use your cameras. Don't even fit. Doggy style. It's gonna hurt your knees. Sorry.
He's underage.
Okay. Now, they're going to call this hips elevated or knee to chest position. This is not on your side. Does laying them on their side give us a gravity assist?
No.
Now, I want you to think how hard this position is. Her belly's going to be about down to here. All right? It's called knee to chest position, but really, it's chest to ground. So get your chest. Try to see how hard it is to actually, don't think about your head. I want you to try to put that on the ground with your hips elevated at the same time.
So
You gotta arch it, Speedy.
Yes. It's hard. It's hard. So
He's
move
not
your
hard.
knees up. No, keep your chest up. I want you to see how hard it is just for guys to do it, but like that. So, also too, think of the ambulance or the stretcher. Which way is the stretcher tilted down on? The feet. You're going to put her facing out the deal. That gives you even more of a gravity assist, right? You're going to put her knees like, so knee to chest position. You're going to really get her chest down there. So I'm going to really get down as hard as you can, but I'm going to, don't move, but Try to really get those hips over there. Get your knees under it. Knees under the chest area.
Not flexible.
But I need the hips, I need your legs straight. Now, hey, look up at the board in front of you. So not stretching, alright?
Not
Alright, but we're gonna try to get these hips as high as we can, and I want her looking forward like that, but I want that chest as close to the ground as I can get it. And that gives us a gravity assist, right? This doesn't give us a gravity assist. That does, okay? Now, we get a little assistance from gravity. Now we take our two gloved fingers, and now we're gonna relieve pressure on the cord. Alright? So, we're riding like this. She's butt naked to the world, got a cord hanging out, got a baby stuck in there, and we're walking in like we're giving the shocker. You know what I mean? But this is how we're transporting in. You need to give them early notification, make sure to cover mom up, and we're going probably straight to OB, or they might do it right there in the field. Okay? But, it sounds funny. You'll do it without even thinking about it, because what are we doing? We're saving a life. Alright? So, two gloved fingers in, keep pressure off the cord. Alright? Now, how you're going to remember this? Alright? Y'all are all so young.